let me introduce you all to Stephanie Reffey, who lives in Texas. She's also a staunch supporter for all things One Cancer Place. She is with Exact Sciences. She's going to tell us her role at Exact Sciences, but most importantly, she's going to tell us about her patient experience as a cancer patient and her transformational experience into that other professional world, and also make herself available as a connection for all of us, hopefully, in just being connected as patients. So, Stephanie, welcome to our little world here. We know you're already part of it, but we want to know all about you.
Thank you, Erica. And thanks everybody for joining us today and being patient as we figured out the Zoom technology. I'm Stephanie Reffey. My current role is Patient Advocacy and Alliance Relations Director for Exact Sciences. I'll talk a little bit about that later. I am also a stage 4 mantle cell lymphoma survivor. Mantle cell lymphoma is a form of non-Hodgkin's lymphoma. It's reasonably rare, so if any of you have heard of it, I'll be surprised. But Janet, okay.
I think I have acquaintance who's been treated for it successfully.
Great. Well, I'll tell you a little bit about my journey as we go along. Before I get into my cancer story, I thought it would be helpful if I just backed up and told you a little bit about my background, because that does feed into how my cancer diagnosis then impacted my career. So and please, if you have a question or you have something to say along the way, I don't mind if you unmute and ask in the middle. Interrupt me anytime. So I am by training a molecular biologist. I got a PhD in molecular biology from the University of Illinois at Chicago. And I did cancer research at the National Cancer Institute for a number of years in the late 90s, really, into a little bit of the early 2000s. I loved bench research. I really enjoyed everything I was doing, but I really didn't feel like I was making a big impact on the world by sitting at a bench and doing what I was doing. So I moved my first pivot from the bench into research administration. And I joined an organization called the Congressionally Directed Medical Research Programs. Some of you may have heard of one or more of their research programs. So they have disease-specific research programs like the breast cancer research program. They now have a colorectal cancer research program. And I managed research programs for the Department of Defense for about 8 years. One of the key things that organization does is they work really closely with patient advocacy groups, and patients and patient advocates sit on the advisory panels for those research programs. They review all the grant proposals, and they are intimately involved in everything about the program, from what the focus is to what they fund, all the way through to helping give presentations and sitting on the research teams that do the work. So I learned a lot about patient advocacy when I was there, and I certainly was what I would call patient friendly. And I was a big believer in the impact that patients had on the research and impacting the future of healthcare for those patients. About 8 years into that, I was recruited by a patient advocacy organization that you may have heard of, Susan G. Komen. They're a breast cancer organization, to help them bring their research program in-house. So I had worked in the breast cancer space for quite a while, and they were looking to hire a team to run their research program, and recruited me to help build that. Of course, it was a patient advocacy organization, so I didn't have a hard time convincing them that we needed to involve patients in that process. And we set up the research program at Komen to integrate advocates at every step as well. So at Komen, there are patients on the board of directors, there are patients on the scientific advisory board, patients help review all those grant proposals as well, and many of the other programs that they do. And then they even insist that there are patients involved in the research and provide training for patients to do that. So still very patient focused and patient friendly. It was while I was at Komen in 2015 that I was diagnosed with mantle cell lymphoma. It was the result of some routine blood work. My white blood count was high. They brought me back and it continued to get higher. It took about 5 months for them to diagnose what I had after a variety of tests. And it was ultimately diagnosed as stage 4 because it was in my bone marrow, but it was slow growing. So they called it indolent and recommended that I do watch and wait. So no treatment right away, just regular checkups. I don't know if any of you have had the pleasure of being on watch and wait. It's not fun. It's probably more fun than going immediately into treatment, but it is still not fun. And I will happily talk to you about that anytime you want to hear about it. In 2016, I had progressed enough that they felt like I needed treatment. My spleen was enlarged, my white blood count was crazy high, and I was starting to have some symptoms. So they recommended that I enter treatment. I had gone to MD Anderson for a second opinion when I was first diagnosed, and they offered a clinical trial to me. So I joined that clinical trial. At the same time, honestly, within about 6 weeks, my mom was diagnosed with triple negative breast cancer. And so I postponed starting my treatment so I could be with her while she had surgery. And we probably coped with our own cancer journeys by worrying about each other the whole time. But we went through treatment together, although not in the same location. So just a little side note, but interesting part of my story. So once I got my mom through her surgery and recovered, I started the trial. I was on 2 biologic drugs, ibrutinib and Rituxan, for 6 months. It was pretty easy. They were infusions, so I had to go in to get the infusions, but I didn't really have a lot of side effects until my very last round, and I got a rash, which is not at all unusual. But after 6 months, they could no longer detect a cancer in my body. So I got to move to the second phase of the trial, which was 4 rounds of hyper-CVAD chemotherapy. Hyper-CVAD is one of the more intense chemotherapy regimens. I lost my hair, all the things. So the picture I think that was on the pivoting ad is from after my last round of chemotherapy. I went and got my head hennaed as a celebration because I had gotten through the whole thing. But I had no evidence of disease, and here I am 6 years later with still no evidence of disease. So I truly do believe that my treatment saved my life. There are many people in my group that haven't made it and or have had recurrences, but I'm still here and I still have no evidence of disease, and I'm very, very grateful for that. I was able to work at Komen the whole time I was in treatment. I did intermittent family medical leave to take time off when I was in the hospital, and then allowed me to work from home when working from home wasn't cool. But I did work full time the whole time. And I really had a hard time navigating through the system. And I thought, if I, with all my knowledge and connections, am having a hard time navigating this system, how does anybody do this? And it's beyond me. I don't know how people who don't have connections and understand the healthcare system the way I do get through it. So kudos to all of you. And it really stuck with me. And I felt like, I work for a patient advocacy organization. I should be able to do something about this. So fortunately, I was, high enough up and had been there long enough that they listened to me. And I started building a program to fix some of the problems I was seeing and that I felt like were in my control. We started training patients about data science and data privacy and the importance of owning your data and having your medical data. I had hand carried my medical records between all my doctors when I was going through treatment, because despite the fact that I signed all the forms and did all the things, they weren't sending them to each other. And I was frustrated by that. So I just carried them around with me. So I did everything I could to work on interoperability of systems, all the things. Again, I have a background in technology and research science, so that was something that was within my wheelhouse to do. We created a program I think I mentioned this already, but we created a program to train patients about data science, and so that they are able to sit in and review privacy laws, tech-heavy data science proposals, and all those things. We did I was very lucky. They let me do a bunch of things to sort of address this problem, and the program is still going on. I'm really proud of it. But the whole time I was feeling like this isn't enough. I need to do more. I felt like I was preaching to the choir. I worked for a patient advocacy group that valued patient input, and I just saw company after company after company that we met with not get why it was important. And I had never really considered going to work for industry before that, but I really felt like I needed to shift, and I needed to put my energy into helping improve the value that is seen by industry of patient input and that patient perspective. And I don't really know that it was that clear to me at first. That's a little bit of hindsight talking, but I needed to round out my experience, and I needed to take my experience as a patient and put it to work in that way. So I worked my network. I called people that I knew. I started talking to them about what it would be like to work for industry. I wasn't really sure I wanted to make that jump yet, but I really felt like it might be time, and it might be something that would be good for me to do. And as luck would have it, somebody in my network was consulting for Exact Sciences and knew that they were looking for somebody to build their patient advocacy program. Like 2 months later, I was on the job. So I started at Exact Science in January 2021 during the pandemic, or towards the end of the pandemic, depending on where you live and how you look at it. So Exact Sciences is a large company. They acquired a bunch of other companies over the last 2 years. And when I joined was right about when they were starting to really grow. You might know them for Cologuard. That's their sort of flagship product. But in late 2019, they acquired a company called Genomic Health. That had a test called Oncotype DX that helps people with early stage breast or colon cancer understand whether they need chemotherapy and which treatment regimen is right for them. So I work for that part of the company. So there's the screening part that does Cologuard, and then they hired me to build the patient advocacy group function within the precision oncology unit. So we now have a large portfolio of tests that I'm happy to talk about if you're interested, that help people understand their risk of recurrence, which treatment it might be best for them. We have an NGS test to match your cancer to targeted treatments. And then we have a test in the pipeline that's about to launch for colorectal cancer that monitors whether you responded completely to treatment or you still have some residual disease and need additional treatment. And then you can use that to monitor for recurrence as well. So we call that our, it's called OncoDetect, but it's a minimal or a molecular residual disease test, MRD test.
MRD, yeah.
Is what that is. So I started in January 2021. I've been there about 2.5 years now. I now have a team of 3 people under me. We work with organizations like One Cancer Place and other patient advocacy organizations that you might be aware of, particularly to educate patients about cancer, about the healthcare system, and about how to have intelligent conversations with their doctors about their care. And we do a lot of work towards health equity and making sure people have access to precision oncology and both the tests and the treatments that help guide their treatment. I love my job. You don't need to be a scientist to do my job, but I feel like my life has led me to this place, and I'm able to combine my history and my skill set with what I'm doing. And at the same time, I get to show this company the value of patients like you and like me and our perspective and how that helps make them better in the end. And I'll be honest, it's been super easy. They were really open to the conversation, which I appreciate. I don't know that every company would be like that. Erica just spoke at our leadership summit a couple of weeks ago. I'm not going to say I don't have to convince anybody of anything, but they're very open, and it's really very rewarding. That's a whirlwind tour, but I am happy to stop and answer questions or go deeper on anything you'd like to know more about.
I want to ask about if you had a moment of enlightenment that catapulted you into this decision to, well, maybe it's the original decision that you had and even going to the research bench. Is there anywhere in the trajectory of your life that you had a moment of aha? Because if you did, I can't believe you haven't, but if you can remember it, I think that's really helpful to know and instructive about who you are and what you've become and the life that you're leading, and very helpful for other people to hear about, if you would care to share that.
Sure. I've had a couple, so I'll pick a couple and tell you about them. One was very early when I was young and went to college. I thought I was going to be a medical doctor. I was always interested in science. I was always interested. My mom was a nurse. I was interested in helping people. And the thing I knew was to be a nurse or a doctor, and being a doctor sounded like more fun than being a nurse. So I went to college pre-med, and I had a mentor, really, my advisor in college, really sort of pulled me aside one day and said, "Have you ever considered research? You think like a researcher." And I hadn't, because I didn't know anybody, and I didn't know what that looked like. But he gave me an opportunity to do a research project with him. I fell in love with it. And so my first aha moment was when I decided to go into research and get a PhD. And I credit him with my whole career, because I would not have been a very good MD. And so I'm very grateful that he saw that and said something to me. And the other one was when I made this jump. And as I was going through treatment and I was struggling myself to navigate care, layered on top of everything I had known from working at Komen for what ended up being 10 years, and the struggles people have, and the barrier between the patient advocacy world and I don't think it's just industry, but I don't have a better word, but the medical business system. I had to do something about it. And working at a nonprofit organization was incredibly rewarding. And I loved every minute of that, but I really needed to find a way to help bridge that gap better than I could sitting in a patient advocacy organization. That's why I started considering going to industry. And that's how I ended up where I am now. And I do feel like I've had several opportunities to do that. I spent last year sitting on a task force to build a framework for patient engagement in the medical technology industry. And I've spoken on a couple panels about it. I really do feel like I'm helping make a difference on that front.
let me make sure that you know that you really are making a difference. You guys need to know that, that working with Stephanie has been a dream since I met her. Now, can I switch gears for just 1 second and go back to your work at the she mentioned the Defense Department.
It's a fascinating story too.
You want to tell it to us?
I'll tell you the quick version. Yeah, that's fine. So in the 90s, early 90s, the US was not at war. We had a budget surplus in the Defense Department. And at the same time, both the HIV/AIDS community and the breast cancer community were lobbying hard for more money for their diseases. And I know the breast cancer side of the story. So the leaders of the breast cancer movement at that time went to Congress and got money to go towards breast cancer. So they started shopping around where that money should go and who should administer it. And they went to NIH first, because why wouldn't you go to NIH first? And I don't remember who the head of the NIH was at the time, but he basically said, we do what we do, we'll happily take your money, but you're not getting a seat at the table. We do what we do.
Yeah.
They weren't happy with that. So they somehow heard that the commanding general at the time would have a meeting with them. And so they met with the general and the leadership of the DOD and made their case. And the general was like, well, this is what we do. You give us a goal, we'll get there. Follow me, ladies, we'll win this battle. And gave them a seat at the table, established the congressionally directed medical research programs to administer the money, specifically for the breast cancer research program. And then they did a good enough job of managing that with a very low overhead, that within a few years, they had, I think, 8 different research programs. By the time I left, there were 16 different disease-specific research programs administered by that department. They are not the same as NIH because they are disease-focused. And the whole process makes sure they're not duplicating what the NIH funds. They do things that the NIH won't fund. Because as you might imagine, they're under a lot of scrutiny from Congress, but they've been really successful. And well, clearly I drank the Kool-Aid. I'm a huge fan, but it's a really interesting story. I know some people who were there when it happened, and they will happily tell you the details.
That's great. I love the stories like this. It all happens at a very personal level. And I love hearing the stories of how that happened and how it's developed. Janet, do you have a question?
So my next question was, so both entities still exist, research funded through the Department of Defense and NIH?
They do, yeah.
Huh. And so, because I know that there's some worry about what's going to happen to research funding through NIH, because I think it's become a popular subject to kick around in Congress in this current environment.
It is. So I'm putting the link to CDMRP in there if you want to look at what research programs they have and stuff. There is a lot, and there should be a lot, because NIH budget's always never a popular cut, but it's an easy cut. And when there are budget issues, it's always sort of on the table, and it's a little super tenuous right now because there's no head, and it's just a little bit of a fragile time. The funding for the CDMRP comes through the defense budget, not through the healthcare budget. So, it's a drop in the bucket for the defense budget. And it's not that they don't have to fight for their funding, but it's not like the NIH, which is the bulk of the appropriation within the way they're budgeted for.
That's very interesting.
Amber, did you have a question earlier?
Yeah, I was just wondering, part of the reason why I joined Stephanie is that I'm interested in being a patient advocate myself. I'm an executive and coach, and I have a master's in marriage and family therapy. And now recently gone through 6 months of chemo for colon cancer, so I'm familiar with that route. And I've seen a lot of, the patient medical community disconnect and talking to friends about different issues that they've had in cancer. And people sometimes I'm finding on either they're not aware of the questions to ask, or they are scared to ask the questions. There's just so many ways of disconnect. And so, being a patient advocate is just sort of would be another string to my bow, as it were, something that I already have a skill set in, and now it would be a different experience. And was a long-winded, but I'm curious, is there a way that you can recommend that we can step in and help? I mean, I'm curious.
So there's a lot of things. Yeah, and we need people like you. So thank you. I think your skill set would be an easy transition, so to speak. So as a company, and not just our company, a lot of companies do regularly look for patient input. We, for example, have a patient advocacy advisory council, 7 advocates from different organizations that just sort of are on retainer to help us figure things out whenever we need it. We do a lot of focus groups. We do a lot of market research with patients and things like that. If you want to get connected into that, in my experience, you're already well on your way because you're connected with Erica, but we usually work through patient advocacy groups to identify people. But an educated patient advocate that can speak well for the group is always sticks out and is always appreciated. The other way that I know that sounds like a lot of work, but just start posting on social media your view, your vision. You'll collect friends and you'll get in the network. And as you get in the network, I can connect you to a few people. They're literally just patients who really developed a passion for this, and now they basically travel around and speak. That's what they do for a living. So they can give you the details of how that all transpired, but it started with just getting their name and their opinion / skills out there. Onto something.
I have a question. So as Erica alluded to, my son came down with he actually came down with appendix cancer at the age of 26, and at 25, I always get this wrong, 25, and died before he turned 27. So he survived almost 20 months. And so my interest, just because I'm a nurse, my husband's a family doc, and we just know that when young people present with GI complaints, it's incredibly hard to identify the person you need to pay better attention to, because there's a lot of GI complaints out there. And so I was really inspired by Dr. Azra Raza's book, The First Cell, and she specializes in non-solid tumors, a very specialized type of them. But she says that that's what's going to have to happen, are non-invasive tests that will look for early evidences of cancer. And so I feel like even Cologuard is going to be the grandpa of the tests that will lead to those early case finding tests. And is Exact working with anything like that?
We are. So we have it's called multi-cancer early detection. MCED. We have an MCED test in the pipeline as well. Our test looks for, I don't need to get too technical here, but circulating tumor DNA in the blood. So it's a blood test that will detect early signs of cancer. Well, even late signs of cancer.
Common. It's common. It's so exciting hearing about some of these tests.
Well, I don't think it's going to come. It's not going to come as fast as people like I want it to come. That's for sure.
Yeah, but it's on the way, but it's not here yet.
To norm it and to figure out who is an appropriate test subject, to know if it has any efficacy, how soon, what could have happened to have had somebody like my son diagnosed before they were stage 4 inoperable. That's the goal to me. That's the grail. That's the grail. And so that's, if I could find a point of advocacy for that would be.
I can hook you up.
Yeah.
And I can share some study data and stuff with you on our test. It's still in the pipeline. We're planning a large scale validation study that will launch next year. But at the moment, it looks really promising, and it can detect about 80 different cancers, most of which don't have screening modality at the moment. Colorectal cancer is the one it does seem to detect that also has other screening modalities.
But the thing of it is to get, we're just seeing, like, the NIH, I think, did a study that I think they funded it, I'm not sure, but basically 4 symptoms that if a young person has GI symptoms and they have those 4 symptoms and they have 2 of that cluster of 4, they have a higher risk, but the symptom cluster is still incredibly common because it's abdominal pain, it's blood in the stools, it's anemia, and then diarrhea. So, I mean, those are not exactly uncommon GI symptoms if you're a primary care provider.
Right.
But the blood in the stool.
For a young person to get a colonoscopy is so difficult.
And we truly, I mean, colonoscopies have their own risk profile. And so, but if you can have a test like she's talking about that narrows down that field of who we should work up more aggressively, maybe progress. Probably my son would have been better served by a CT of the abdomen than a colonoscopy. But even then, to figure out who you're going to be more aggressive with, so that, I mean, just in the colon cancer community, people being diagnosed holding newborns in their arms, harsh. It's harsh.
I had a question.
Yes.
Just, I kind of, maybe it was not necessarily specific to, I guess, the testing itself, but just thinking about like patients as well, as you've been, Stephanie, in the patient advocacy community for quite a while, but thinking about, you had mentioned MD Anderson, and they offered you a clinical trial, which is great. I mean, that's definitely something that we need more patients being offered our clinical trials earlier in their treatment. But also thinking about like the community setting too, where unfortunately, the majority of patients, I think, receive their treatment. Is there a way that we can bring, is there some kind of ecosystem that's being built out maybe to help provide more clinical trials? I mean, I know the decentralized clinical trial model is, I think, seems to be catching on a little bit more now after COVID, but I'd like to really be able to, provide a larger array of, options to patients who don't have easy access, perhaps, to, a large academic research center. What do you see maybe happening in that space?
I know a lot of people are working on it. So I believe we will get there, and I believe we will get there sooner than later. There's just, like you said, COVID helped us move along a little more quickly than we probably would have otherwise, just because we had to figure out how to keep people safe and still get things done. So, but we figured that out. It's the community setting is hard, and that's our exact main customer are the community clinical clinics and the community oncologists. And they're so busy that they just adding one more thing is a lot. So it's working with the system to make things easier. It's putting in education so that both patients and physicians understand that a clinical trial is a viable treatment option, right? It's not a last ditch effort. It's really in many cases, the cutting edge. In my case, I didn't really go into this when I was sharing, but for the kind of cancer I had, the current standard of care was just straight chemotherapy. And it basically, they said it won't knock it out. It'll just knock it down. Like they couldn't get you to no evidence of disease. So it was just a constant cycle of knocking it down, and then it would come back, knocking it down, then it would come back until you didn't respond anymore. And
Would
then
they recommend that? Did they recommend that to you?
My local doctor did. Yeah.
Whoa.
And then MD Anderson said, there's this trial and we don't know, but we think that there's evidence to suggest that it could knock it out. So I tried it and it did. I'm 6 years later, no evidence of disease. And there are people in my group who are 8 years, we're sort of the pioneers here, but
Yeah.
there are people living quite a while with no evidence of disease now. So that's different. Not every trial is like that, but, less side effects, all kinds of benefits to trying new treatments, as long as there's good evidence that they work. And for them to make it that far, they have to have some good evidence. So I hear you. People are working on it. Exact is, as far as we're concerned, when we run a trial, we are trying to include federally qualified health centers and some more local clinics, as opposed to just only the academic medical centers. But the academic medical centers have the infrastructure in place and it's easy for them. And you have to set all that up at these smaller organizations. So it's just priorities, and
The onboarding is a lot faster.
yeah.
Yeah. There's just lower barriers altogether. Yeah. No, I get it. It's good to know what's out there and kind of what's
A lot of people working on it. We are absolutely going to get there, but I don't know when.
I want to emphasize that there are a lot of interesting stories. We'll never run out of interesting people to present to you at Pivoting, and hopefully what this does is eradicate those barriers, that exist, because now one has been broken and broken down by Stephanie. And so Stephanie, you'll have to tell us how you want us to communicate with you.
I am on Facebook and LinkedIn both. I'm happy to connect that way. Erica has my contact information. I'm sure she doesn't want to sit in the middle, but she can put you in touch with me. That's fine as well. Okay. Amber sent me a message in the chat saying she wanted to connect. So I was just finding her on LinkedIn and connecting while you were talking.
Good.
So I'm happy to connect with any or all of you. I'm happy to introduce you to people or facilitate things. Janet, I'm going to put you in contact with our MSED person, and I'm sure she will be happy to leverage your passion.
That's great. Just know that any way that I can help, I'm like Stephanie. Gina's the same way. Any way we can help make connections that are going to be useful to everybody. No connection is a bad connection.
I think learning to leverage those encounters, which I'm not fabulous at, I think that's an important skill. I talked to a guy who is, I think, in charge of the GI research at NIH, and I totally didn't leverage that as well as I could have. But the time I spent talking with him was really valuable to me. But
what do you mean by by leveraging?
Just because I'm like, I should have given him one of my little cards, one of my One Cancer Place cards. And, I went on the website and made sure I saved the connection so that I can be more diligent about knowing his name. You know what I mean?
You should do. Do you have his name and his contact information?
Well, in that, he lives, he in Washington, D.C., and he's at NIH or wherever,
Do you have his email?
I can't remember if I think, he's a government employee.
You're discounting your own value, Janet.
Yeah.
Right there. And it's never too late to send an email saying, I met you, could have been 10 years ago. I've never forgotten you.
And I'll just add to what Erica is saying. It's not too late to follow up. People in research in particular, it's so unusual to get a chance to speak to a patient or to a caretaker. I wouldn't be at all surprised if he doesn't remember you. So yeah, I mean, if you need help trying to find his email address or something.
No, I had him
probably help,
saved
but-
on my computer just because I wanted his name and his face to be something that I could remember. And I also, I'm on X, formerly known as Twitter.
Yeah.
And I get the NIH postings on the prevention end.
Mhm.
The early, to me, because what Dr. Raza said is, about the idea that we were going to ever save my son's life, finding his case as late as we did. That's silly. It's absurd even. And so we do have to do that earlier case finding, and the treatments will be less intrusive and less invasive for early case finding. And if I'm right, and if the person I know also had mantle, the bar for starting treatment was incredibly high. And she had this huge lymph node on the side of her neck that my friend, also a nurse, could see from the doorway. And Rose was like, yeah, it's not big enough to treat. That's what they tell me. So if she had the same cancer, and I thought how horrible that would be, to be in that boat. And one of her kids got on the internet and found out that Fred Hutch was doing some work on that cancer. Mm-hmm. And they said, you're going to go to Fred Hutch. And I think that that's what they did. They probably put her into an immuno trial of some variety, and she's living her life now. She's coaching, retired and coaching volleyball and taking care of grandbabies,
It very well could be the same thing because, like I said, I was on watch and wait for almost 2 years. And by the time, so I continued to see my local oncologist, and then I would go down to MD Anderson periodically just to check in because that's where I got a second opinion. And the local oncologist was still watching and waiting. And MD Anderson was like, your spleen is filling up your abdomen. We have to do something. Yeah. And then I saw the CT scan, and I'm surprised I wasn't more uncomfortable than I was because it was huge. So it very well could be exactly what you're saying.
Mm-hmm. And then there's other cancers that are fast growing, and within 6 months, you have stage 2 or 3, and it's such a variety, maybe, because your local oncologist
and even
know everything about everything, I guess. You know?
Well, and I come from the breast cancer world, and some breast cancers are growing very slowly, and some of them grow very fast, and even the same kind of breast cancer, we got to get better at. What
I'm noticing in October is that there's more communication about the variances in breast cancer finally. And I'm seeing more and more of those messages to the consumer that are saying this is not just one disease, this is a multitude of diseases. Yeah. Mm-hmm. Alicia, do you want to introduce yourself to us? I think you should. You're the one that we don't know as well.
Oh, okay. Well, sure. Well, I'm Alicia Dietrich. I also have a PhD in molecular biology, but so I'm actually going through treatment right now. Currently, it's just been rather recent, just kind of a strange, weird thing that, I kind of had on my radar as a previvor. I had a BRCA1 alteration, mutation in one of those genes. So I was aware that it could, very well, I could very well develop something, but, just based on family history, it was, I felt comfortable doing my screenings, and, it's like every generation now with someone in my family, it's like, the cancer is becoming, 15 to 20 years earlier in within the generation. So it's something that, unfortunately has hit me a little earlier, but, so I'm just trying to do my best to I definitely want to make a more of an effort to get out and know more patients individually about, learn everyone's stories as much as possible. I mean, I had kind of had, being a pre-viver, I had an interest in pivoting to the full-time patient advocacy world previously, but it just, timing just wasn't really quite right yet. So I'm just kind of taking a break for now, and, not really a break, but, I'm certainly trying to make as many connections as I can while I have, while I'm not.
Alicia, if you don't mind, she's a very poignant recent story. I think you should tell people what happened.
Just with
Your diagnosis.
Right. So, I mean, I am in treatment for a triple negative breast cancer. So I understand, Stephanie, your mom, too, that whole treatment regimen, although it sounds like maybe she had done surgery first and then chemo. I mean, I know now with the Keynote 522 trial that, seems to have, that's been practice changing. So I was a T1C diagnosis, and I've seen a local oncologist just because he has always been so, he was a second opinion for me, but he's been very adamant about, he's very pro Keynote 522, and he felt very strongly about those results and what, the benefits that it had. I mean, just bringing even 10 to 15% more complete response, more patients to that threshold, he felt very strongly about, and he was able to advocate for me with my insurance and getting me Keytruda, as a first line response, even though I technically didn't meet criteria for that. My tumor was just maybe 7 millimeters too small, so I wasn't technically at stage 2, but clinically, a month after doing my first MRI where they had found a nodule, he was able to measure it at a stage 2, just because insurance was so, trying to get everything on board and trying to, meet with physicians to begin with. I had that month in between where, I'm sure as you are very familiar with, Stephanie, it was very anxious, a very anxious time of not knowing, and I just had a mammogram in January where it was all clear. Nothing had been seen. And, but thankfully I am able to get on, I'm using Keytruda, as a first line treatment at my stage. And I'm thankful for that, even though I am technically now stage 2 because he was able to measure it. Yeah, I know numbers, right? It's like,
No, but that's how fast it grows. Yeah.
I mean, it's all localized. It's just the size of the tumor, the primary tumor. I mean, at least for breast cancer, I'm not as familiar with, what some of the stages mean maybe in other cancers, but so it's
informed. It's really interesting that this trial sounds really interesting, isn't it? It's the beginning in breast cancer, using Keytruda in breast cancer. And we want to know this stuff. We want to know that, we want to hear the success stories and the everything stories, Alicia. So that's really wonderful that your doc did that for you. And that's also a story of personal activism on your part to make sure to get to that doc.
Yeah.
Make sure that you just weren't content until you got some answers. So keep it up. You're a role model for other patients. Remember that.
I think it makes a difference in having them be independent as opposed to maybe someone in a larger healthcare setting. I mean, he wasn't my first opinion wasn't at, a large academic healthcare center, but he was still part of a healthcare center. And I think, they were restricted to, okay, you don't meet these criteria. This is a strict criteria. This is your treatment. And so I was like, well, is there more? And so it's something that's hard. It's definitely hard. It's not easy trying to navigate that whole system for sure. So I feel for everyone.
Well, good luck. My mom was diagnosed stage 3. She had a 6 centimeter tumor and had a clear mammogram 4 months earlier.
Yeah.
Fast.
She
Woo!
did neoadjuvant TAC, then had a mastectomy, and then they followed up with some additional chemotherapy after because they still found residual tumor. But she's 6 years clean now. So,
Oh, wonderful. That's,
Can I ask, Stephanie, if in breast cancer, if a tumor like your mother's was fast growing, obviously fast growing, triple negative,
mhm.
were she to, what are the recurrence numbers? And would it be again the same type of growth?
So it varies from subtype to subtype. Triple negative more often recurs quickly. So if you
So to have 6 years is really good.
if you cross the 5-year line, you're in pretty good shape with triple negative. I don't know that we know how many people recur, but it's a lot in triple negative.
Yeah.
For other subtypes, like for ER positive, HER2 negative breast cancer, which is the most common type, many people live a very long time after having that, but they recur 15 or 20 years later. And then
they have exquisite surveillance, right?
Yeah. Yeah. The 30% gets thrown around a lot. I don't like that number because I know how they came to it and I don't trust it, but that's about 30% of cases recur across the board, across all subtypes.
All breast or all cancers?
All breast.
All breasts.
Yeah. Wow.
Well, good learning. I love these discussions because there's always something more to learn.
I've been around for a long time. I have a lot of information, so and I am not afraid to pick up the phone and call somebody. So
she has a lot of friends, guys. That's a real generous offer, Stephanie. Thank you very, very much.
Yeah, thanks.
Does anybody else have any more? Anything? What do you think? Do you like this idea? You like it?
Mhm.
Oh, good. Amber, you do?
Yeah, I think it's great.
Alicia?
Yeah.
Yes.
Yeah,
Yes.
I love it. I mean,
Great. Thank
Just
you.
to have these conversations and to be able to meet other patients and caregivers and those who are in the, just really living it is really great.
Well, that's us.
thank you for having me.
So we didn't
Fun.
talk, I spent like the last 3 years of my official work life doing care management on an inpatient rehab unit in a hospital, which is not oncology. I've never worked in oncology, but we didn't talk about insurance as a barrier to care, but it really is.
Mhm.
And you were talking, Alicia, about your doctor and their group and how tied they were to standard of care. And especially if they are a gatekeeper to your insurance, that's a big deal. It is. And so learning, it's massive the way insurance decides who gets what. And when people don't have insurance, it's almost sure that they won't get very much.
I was literally twice it makes me want to cry. Twice when I was getting chemo, there were people in the bay next to me talking to the nurses or whoever about the fact they couldn't afford their next treatment. I was just being English, I'm used to the English system where it's free. I mean, it's on its knees, but it's free. And to really hear that people cannot get life-saving treatment like that. They do. One person was just like, yeah, I need chemo in a couple of weeks, my next session. How much would it be? And the nurse had said, we've tried getting grants for you. We've tried this, that, because they have advocates there. And just heartbreaking to listen to that conversation.
It's, so I mentioned I was on ibrutinib as part of my treatment, and that's one of the highest priced drugs out there. It made the first list for the FDA price negotiations. And it was covered for me because I was on the trial, but I stood at the line with the pharmacy with people in tears because it's $100,000 a month, and even a copay on insurance is $10,000 to $15,000 a month. And who can do that? For
Who can do that?
I'm gonna have to go, guys. Sorry.
Yeah.
For the
We're glad
conversation.
you came, Amber.
Thank you.
Very glad to.
I'm going to drop out too.
Thanks,
Yeah, it
Janet.
was good meeting everyone. I'm gonna.
You too. Bye.
Thank you, Alicia. It was wonderful having you. Come again.
Sure, yeah, absolutely. Look forward to the next one.
Good. I do too. It's going to be fun.
Yeah.
That is a real hoot. Thank you, Stephanie. That was great. Having you as part of this is just amazing.
I know.
Thank you.
We love you, Stephanie.
I love you too. And I am honestly, I'm happy to do it. I'm honored that you asked me. So.
Bye, Gina. Thanks.
Bye.
Bye.